All right, diving in today, folks, we're tackling a concept that's absolutely crucial in healthcare.
Yeah, really sits at the intersection of law, ethics, and even bumps up against some pretty deep philosophy, doesn't it?
You got it. And I think our listeners, especially with their philosophical backgrounds, will appreciate that. We're talking about decisional capacity.
The very ability to make one's own medical decisions, to consent to or to refuse treatments or to participate in research, it all hinges on this.
Exactly. It's about respecting individual autonomy, recognizing that each person, ideally, has the right to direct their own life, their own medical journey.
Right, and historically, this wasn't always the case. The concept of decisional capacity emerged alongside informed consent.
Kind of a pushback against that old paternalistic model of medicine where the doctor knows best and the patient just follows along, huh?
Absolutely. It was a shift towards empowering the individual, placing the authority over medical decisions squarely where it arguably should reside with the patient themselves.
But of course, it's never quite that straightforward, is it? We run into some very tricky situations.
Definitely. I mean, there are the clear-cut cases, someone who's unconscious, an infant, someone with severe, irreversible brain damage.
Right. Those are more straightforward. But then you get into the gray areas.
Absolutely. Individuals with maybe partial cognitive impairments or fluctuating mental states, and then the stakes get really high, both ethically and practically.
Because if we get it wrong, if we misjudge someone's capacity, the consequences are huge.
Absolutely. We could fail to protect a truly vulnerable individual, someone who doesn't genuinely grasp the situation.
Or, on the flip side, we could wrongly strip someone of their right to self-determination, deny them the agency that they rightfully possess.
Exactly. A false positive, if you will, in assessing incapacity is just as troubling as a false negative. So our deep dive today is all about unpacking this concept, decisional capacity, in all its messy glory.
We'll break down the terminology, examine the assumptions baked into how we think about it, and as you mentioned, we'll bump into some pretty enduring philosophical challenges along the way.
And ultimately, bring all this back to how a philosopher, someone deeply interested in questions of agency and decision making, might approach these issues.
So I think a good place to start is with the language itself, right? Even the terms we use can be a bit slippery. In medical settings, we hear decisional capacity and mental competence tossed around almost interchangeably.
Yeah, like they're synonyms. But is there a meaningful distinction there, especially for someone coming at this from a philosophical perspective?
Right, because I know that in other legal contexts, competence has a much broader meaning. Like think of competence to stand trial.
Right, that's a completely different ballgame. There, competence encompasses a whole bunch of legal knowledge. Do they understand the charges against them? Can they assist in their own defense? They don't need to be, legal scholars, but they need a certain level of grasp of the legal process.
Which is very different from the abilities involved in making a medical decision, right? Whether to accept a particular treatment or refuse it.
Exactly. So, a crucial point here is that while the terms often get blurred in casual conversation, in medicine, capacity is generally focused on a specific decision at hand.
Okay, so someone declared legally incompetent, in a broad sense, might still have the capacity to make a particular medical choice.
Absolutely. In fact, the trend in medical ethics and law has been moving away from those broad assessments of competence towards what we call a decision relative approach,
Meaning?
meaning we assess someone's capacity to make this particular decision right now in this context, not their general ability to manage their affairs.
So someone with early stage dementia, for example, might be perfectly capable of deciding about a routine flu shot.
Right. But that same person might lack the capacity to consent to, say, a complex experimental surgery, and even their capacity for that flu shot decision, it could vary day to day,
Mhm.
depending on their condition.
It's fascinating how much context matters here. Now, there's also this distinction often made between clinicians assessing capacity and judges determining competence. Is that a hard and fast rule?
It's a good guideline, but like most things in this field, it's messy in practice. Clinicians who are evaluating capacity, they're making judgments that carry a lot of practical weight.
So even without a judge formally declaring anything, the clinician's assessment can essentially function as a legal determination.
In many cases, yes, unless it's specifically challenged. And conversely, even when judges are involved in medical decision cases, their focus is often narrowed down to the specific capacity for that particular medical choice.
Not necessarily a sweeping declaration of global incompetence, huh?
Exactly. And to add another layer of complexity, the legal weight of these terms can even differ depending on where you are in the world. In the UK, capacity itself carries legal standing, while in the US, it's more often competence.
So, navigating this terrain, even just at the level of language, requires some careful attention. Buchanan and Brock even propose a new term, decision-making competence, just to try to be more precise about the abilities involved in specifically healthcare choices.
Yeah, but honestly, even that hasn't fully caught on. You still see all these terms being used, sometimes even by the same people.
I guess the key takeaway for our listeners, especially for those approaching this philosophically, is that while we might use decisional capacity and mental competence interchangeably, the underlying concepts are not always perfectly aligned.
Right. They have different histories, different legal nuances. It's important to be aware of those complexities, even if, for the sake of our discussion today, we're using them more or less as synonyms.
Okay, so we're grappling with some loaded terminology here.
Yeah.
And it seems like even when we do assess someone's abilities, the factual side of things, that's not always the end of the story.
You're hitting on a really crucial point there. There's the descriptive side of capacity. Does the person actually possess the cognitive abilities to make a decision? Can they understand the information, weigh the options, communicate a choice? And then there's the prescriptive side.
Meaning?
Should they be allowed to decide, even if they technically can? So let's say a clinician does a thorough evaluation and concludes descriptively that the patient has the capacity to make this particular medical decision.
Right, they tick all the boxes in terms of understanding, reasoning, etc.
But then a court might step in and make a prescriptive judgment, saying, well, given those abilities and given the potential consequences of this choice, we're not going to honor that decision.
So the descriptive assessment doesn't automatically dictate the prescriptive outcome.
Exactly. There can be legal or ethical considerations that override a purely descriptive finding of capacity.
And this interplay between the descriptive and the prescriptive, it seems to happen at different levels, right? It's not just about the individual assessment. We're also talking about how we even conceptualize capacity in the first place.
Absolutely. We could even map this out in layers. You've got the very concept of capacity. What is it we're even trying to capture with this idea? What's the goal? Then you've got the standards. What specific abilities must someone demonstrate to be considered capable?
Right, and those standards, we'll get into them in detail later, but I know the widely accepted ones are choice, understanding, appreciation, and reasoning.
Exactly. And then you have the level of tests and instruments. Those are the tools we use in practice to measure whether someone actually meets those standards. Like the MCAT is a commonly used one.
Okay, so concepts, standards, instruments. And I guess disagreement can pop up at any of those levels.
Absolutely. You might have someone arguing that a particular test isn't accurate, that it doesn't really measure what it's supposed to. Or someone might say the standards themselves are flawed. Or even challenge the whole concept of capacity. It gets really interesting.
So lots to unpack there, but before we get too deep in the weeds, I think it's important to take a step back and ask about the moral grounding of this whole concept. Why do we care about decisional capacity in the first place?
It's not just some arbitrary hurdle we put up. It's deeply tied to the ethical principles that guide healthcare. And you already alluded to one of them earlier, informed consent.
Which itself was a response to medical paternalism, right? Recognizing that patients should have a say in their own care.
Exactly. The moral purpose of informed consent, really, is to promote and protect patient autonomy. And autonomy, for philosophers like Beauchamp and Childress, stems from the inherent dignity of each person, their capacity to make choices that shape their life, their moral path.
So this connects back to the idea that people should ideally have the freedom to direct their own lives, right?
Precisely. And that includes healthcare choices, whether it's accepting a recommended treatment, refusing it, or even choosing to participate in research.
But that freedom, that right to choose, it hinges on having the capacity to make those choices in a meaningful way. That's where decisional capacity comes in.
Right. You can almost think of it this way. We have this moral obligation to respect people's medical choices. But to figure out who deserves that respect, we need some way to determine who's actually capable of making those choices in a way that aligns with this whole idea of autonomy.
So decisional capacity is like the gatekeeper to genuine informed consent.
Precisely. It's a core requirement alongside the provision of information, the patient's understanding of that information, and crucially, that their decision is voluntary. It's not coerced, it's truly their own.
Okay, that makes a lot of sense. It's interesting to me that you mentioned earlier how the concept of decisional capacity wasn't directly derived from abstract philosophical theories of autonomy. I kind of assumed it was the other way around.
I know, right? It seems intuitive to think we started with these grand philosophical ideas and then tried to apply them to the messy reality of healthcare. But it actually went the other way.
So instead of this top-down philosophical approach, we ended up building the concept of capacity from the ground up, dealing with real cases, real ethical dilemmas.
Exactly. It arose more organically from the practical needs of the healthcare system and the ethical considerations at play in those specific situations, which to me raises a fascinating philosophical question. Does a competent decision, in this practical sense, always align with what a philosopher would consider a genuinely autonomous decision?
Yeah, that's a big one. We might have to dedicate a whole other deep dive to that.
Absolutely. For now, I think it's just important to keep in mind that tension between the clinical world and the philosophical world. They don't always see eye to eye. Now, shifting gears a bit, let's talk about what happens when someone is deemed to lack decisional capacity. What are the moral implications of that? What ethical considerations come into play?
It's a heavy situation for sure. Because if the person themselves can't make the decision, who does? How do we ensure that we're still respecting them, even in their incapacity?
Right, and the standard answer is we turn to a surrogate decision maker, usually a family member or someone designated by the patient in advance. But, and this is crucial, even when someone lacks capacity, their current wishes, their values, those don't magically disappear. We have an ethical obligation to take those into account.
It's not just a free-for-all for whoever's making the decisions now. We can't just impose whatever treatment we think is best, especially if it clashes with what the patient, however incoherently, might be expressing.
Absolutely not. Forcing treatment on someone lacking capacity can have some pretty negative consequences. It can be practically ineffective if they resist, and especially in cases of long-term care, it can damage that crucial trust between patient and provider. Remember, even without full decisional capacity, the principle of beneficence, doing good for the patient, has to be balanced with respecting the individual.
You also brought up a really interesting challenge from Jaworska about those cases where someone is now globally incompetent, maybe due to advanced dementia, but they were once competent and had made advanced directives.
Right. It forces us to ask, how much weight should those prior directives carry? Especially if the person's current expressions, even if they seem simple or fragmented, suggest a different path.
She makes a strong case for considering the persistence of values even when decisional capacity is gone.
Exactly. She points out that even someone with mid-stage Alzheimer's, they might still retain the capacity to value things. They might still have preferences, things they care about, things they want to avoid, even if they can't grasp complex medical information or reason through the options the way they once could.
So the key insight there is that the various capacities that make up personhood, they can come apart.
Right. We often privilege understanding and reasoning because they help us pursue the things we value. But someone can still have those values, even if they've lost the tools to deliberate effectively about how to achieve them.
Which suggests that, ethically speaking, sometimes honoring what the person is currently expressing, however limited it might seem, could actually be more respectful of their personhood than rigidly adhering to a document created years ago.
Exactly. It really pushes us to rethink what matters most when we're talking about respecting someone, even in the face of significant cognitive decline. It's a profound philosophical question, really. Okay, so far we've been dancing around the specific elements of decisional capacity. What does it actually mean to be capable? What are the abilities involved?
Right, let's get into the nitty-gritty now.
Okay, so the four widely agreed upon components, those subcapacities, are choice, understanding, appreciation, and reasoning.
And we'll get to this later, but there's some debate about whether this list is complete, whether things like value and authenticity should also be in the mix.
Oh, absolutely. Plenty of philosophical meat on those bones. But for now, let's stick with these four core abilities.
Starting with choice. It seems kind of obvious, right? The ability to express or communicate a preference. Why is that even considered a separate element?
You'd think it's self-evident, but it's important to remember that not everyone who possesses the mental abilities to understand, appreciate, and reason can actually express their choice.
Like, they might understand what the doctor is saying, but they're physically unable to communicate their decision.
Exactly. Think of someone with advanced locked-in syndrome, or someone who's had a severe stroke affecting their speech or motor function. Their mind might be sharp, but they're trapped. So even though choice seems like the most basic element, it's absolutely essential for respecting someone's autonomy. Without it, we're back in the dark, unable to determine their will.
Makes sense.
Yeah.
Okay, next up, understanding. This seems pretty straightforward, too. You grasp the relevant facts about your medical situation, the treatment options, the potential risks and benefits?
In theory, yes. But even defining what constitutes sufficient understanding is a philosophical rabbit hole. At the bare minimum, it requires some basic comprehension of the key information.
Right, just parroting back the facts isn't enough. You have to grasp what they actually mean for you.
Exactly. The standard can't be so low that we're calling someone capable when they really haven't grasped the implications. But on the flip side, we don't want to set the bar so high that we exclude tons of people who are, for all practical purposes, capable of making an informed choice. Finding that sweet spot is tricky.
And then we move on to appreciation, which seems to go a step further than just factual understanding.
Exactly. It's not just knowing the facts, it's also believing them, recognizing their personal significance. It's often described as having insight into your situation.
So I could intellectually understand what my doctor is telling me about my illness, but because of delusion, maybe,
Yeah.
I don't actually believe it applies to me.
Right, that would be a failure of appreciation. And it's important to distinguish that from someone who, say, refuses a blood transfusion based on their religious beliefs as a Jehovah's Witness. Their refusal isn't due to a lack of understanding or a delusional belief. It's rooted in a deeply held, internally consistent worldview.
Makes sense. And I remember you gave that poignant example of an elderly woman who had developed gangrene in her foot. She understood the facts about the proposed amputation, but she kept talking about how her foot would heal soon. That seems like a classic case of lacking appreciation.
Exactly. She understood intellectually what the doctors were saying, but she didn't truly grasp on an emotional level the severity of her condition, how dire the situation was. And some theorists argue that appreciation goes even deeper than that. It involves not just understanding your current state, but also understanding potential future states and integrating that into your decision-making.
Oh, wow. That adds a whole other layer of complexity, doesn't it?
Right, it gets really tricky to assess that deeper level of appreciation, partly because humans are notoriously bad at predicting how they'll feel in the future, what we call effective forecasting. And there's always the worry that we might set the bar too high, end up labeling people incapable just because they don't have a perfectly clear crystal ball.
Okay, so choice, understanding, appreciation, and finally, we have reasoning. This seems like the ability to think things through rationally, weighing the options, considering the consequences.
Exactly. It's the mental process that connects your understanding and your appreciation to the actual formation of a decision. It's about being able to manipulate the information in your head, to consider the potential risks and benefits, to evaluate the likely outcomes of different choices.
So it involves things like logic, judgment, and the ability to make inferences.
Exactly. And interestingly, in discussions about decisional capacity, the concept of reasoning is often kept a little vague. Intentionally so. We don't want to impose overly specific standards that might be too restricted, that might unfairly label people incapable just because their reasoning style doesn't fit some narrow mold.
So it's more about the process of reasoning, rather than whether we agree with the particular conclusion someone reaches.
Right. Some examples of normative standards for reasoning might be, is the person's choice consistent with their stated values? Can they draw logical conclusions from the premises they've been given? But again, the emphasis is on the process, not the specific content of their thoughts.
Okay, so we've got these four abilities, generally considered necessary for decisional capacity. But, and you've hinted at this throughout our conversation, the big question is, are they always sufficient?
Right, and that's where the philosophy really kicks in. Critics of this four abilities model point to cases where someone seems to tick all the boxes, but owes choice, understanding, appreciation, reasoning, but intuitively, we just don't feel comfortable saying they're truly capable of making a sound decision.
So there's this gap between the model and our gut feeling, like something's missing.
Exactly, and that's led to a lot of discussion about what those missing pieces might be. Emotions, values, authenticity, these are all contenders for expanding our understanding of capacity beyond these purely cognitive factors.
Lots to explore there. But first, I think it's helpful to lay out the groundwork, the assumptions that we're building on when we talk about decisional capacity.
You're right. Because these assumptions, they shape everything else. They form the foundation of our whole approach. So there are 5 core assumptions that are pretty widely accepted. Inclusivity, decision relativity, all or nothing assessment, value neutrality, and independence from diagnosis.
Okay, and then there's a sixth one, risk and symmetry, which is a bit more controversial.
Exactly. We'll get to that one, but let's start with the uncontroversial ones. Inclusivity first.
This seems like the idea that we should err on the side of presuming most adults are capable of making their own decisions most of the time.
Exactly. It's tied to our societal commitment to individual liberty, to minimizing restrictions on people's choices. And it's also essential for the whole concept of informed consent to even make sense. If we were constantly second-guessing everyone's capacity, the whole system would fall apart.
Right, it would be paralyzing. So we have to start with a presumption of capacity, then work from there. Okay, next, decision relativity.
This one is so important. It's the understanding that capacity isn't some fixed trait, some global attribute that you either have or you don't. It's relative to the specific decision being made at that particular time in that specific context.
So my capacity to decide about taking an aspirin for a headache is going to be different from my capacity to decide about, I don't know, donating a kidney.
Precisely. Different decisions require different levels of cognitive ability. And even for the same decision, someone's capacity can fluctuate. Think of the dementia example earlier, or someone whose mental state is affected by medication side effects or an acute illness.
So we're moving away from that old school view of capacity as this fixed thing, like you're either competent or you're not, period.
Right, and a good example of that outdated thinking is the mini mental state exam, or MMSE. It used to be quite common to just use that as a blanket assessment of competence, but it's a very global measure. It doesn't account for the nuances of different decisions.
So the legal and ethical thinking has shifted towards more case-by-case, situationally sensitive assessments, which makes a lot of sense, honestly.
Absolutely. All right, next up, all or nothing assessment, which seems kind of strange when we just said that capacity exists on a spectrum.
Yeah. How do those two ideas coexist?
Well, the all or nothing aspect is really a practical necessity because in the healthcare system, in the legal system, we need a clear answer. Who gets to make this decision? The patient or someone else?
Right. We can't have this wishy-washy, well, they're kind of capable, kind of not situation. We need a definitive yes or no.
Exactly. So even though we acknowledge that capacity exists on a continuum, for the purposes of assigning decision-making authority, we have to draw a line in the sand.
Okay, that's fair. I get it. Now, value neutrality. This one seems particularly relevant for our philosophy-minded listeners.
It really gets to the heart of respecting individual autonomy. The idea here is that we shouldn't deem someone incapable just because they're making a choice we disagree with, just because their values are different from ours or from what's considered normal.
Like, if someone refuses a life-saving treatment because of their religious beliefs, we shouldn't automatically assume they're incompetent just because we think that choice is irrational.
Exactly. We have to distinguish between a choice that's unconventional but stems from a competent decision-making process rooted in their own values versus a choice that's truly the result of impaired cognitive abilities. Someone might prioritize quality of life over longevity, even if that means foregoing a treatment that could extend their life but with significant side effects.
Right. And who are we to say what the right values are in those deeply personal situations?
Exactly. The principle of value neutrality is all about protecting individual autonomy, even when those choices seem strange or even harmful to us, as long as the decision-making process itself is sound.
Okay, so this is where the distinction between process and outcome becomes really important.
Absolutely. In assessing capacity, we're focusing on the internal rationality of the decision, meaning, is the choice consistent with the person's own beliefs and values? Does it make sense from their perspective, even if we disagree with it? We're not judging the outcome itself. We're looking at how they got there.
And this, again, ties back to respecting individual values, even when they lead to choices we might not personally make.
Right. Even if someone's choice seems objectively harmful to us, if it arises from a process that's internally rational, if it's consistent with their own system of beliefs and values, we generally consider it a competent choice.
But this principle of value neutrality, it's not without its critics, right? Culver and Gert, for example, they argue that irrationality can sometimes be judged by the outcome, even if the process seems rational.
Yeah, they're famous for their example of someone with severe depression refusing ECT. They argue that even if the person's refusal seems rational based on their current state, their deeply negative beliefs, their fear of the procedure, the fact that refusing it leads to such a harmful outcome, to prolonged debilitating suffering, suggests a deeper irrationality that we can't ignore.
So they're saying, look, sometimes the outcome is so bad, so contrary to what most reasonable people would want, that it casts doubt on the capacity of the person making that choice, even if their reasoning process seems sound on the surface.
Right. They even suggest that we should consider, quote, how most reasonable people would judge the likely outcome, unquote, as part of the assessment.
But that gets pretty tricky, doesn't it? Who gets to decide what's reasonable in these deeply personal, often life or death situations?
Exactly, and that's the main counterargument to Culver and Gert's view. Relying on some external standard of reasonableness risks slipping back into paternalism, imposing our own values on someone else. The prevailing clinical consensus still favors the more process-oriented approach, really to protect individual autonomy and prevent clinicians from just overriding patients whenever they disagree with their choices. It's messy, no doubt.
It really highlights how much philosophy is baked into these seemingly clinical decisions.
Totally. Okay, moving on to independence from diagnosis. This one seems pretty straightforward. It means we don't automatically assume someone lacks capacity just because they have a particular diagnosis.
Like a mental illness or a cognitive impairment.
Exactly. This principle is a safeguard against historical injustices where people with mental health conditions were routinely denied their basic rights, their agency. The focus now is on whether this specific illness actually undermines the person's capacity for this particular decision.
So, does their schizophrenia, for example, demonstrably affect their understanding, their appreciation, their reasoning about this specific treatment choice? Not just, oh, they have schizophrenia, therefore they're incapable.
Right, and this shift has led to much greater respect for the autonomy of people with mental health conditions. It's helped reduce stigma, and it's promoted their involvement in their own care.
Okay, that brings us to our final assumption, the controversial one: risk and symmetry.
The debate here is whether consenting to a treatment and refusing that same treatment should always be held to the same standard of capacity.
So if the risks associated with each choice are vastly different, should the bar for capacity be adjusted accordingly?
That's the argument for asymmetrical thresholds. The idea is that refusing a treatment that's low risk but high benefit, a treatment that could potentially save your life, should require a higher level of demonstrated competence than consenting to that same treatment, because the stakes are just so much higher with refusal in that case.
So it's like a sliding scale of required competence, depending on the potential consequences of the choice.
Exactly. Proponents of this view say it's a way to balance our obligation to respect autonomy with our obligation to protect people from harming themselves. But critics push back hard, saying, look, our cognitive abilities don't magically change based on external factors. And if the whole point of capacity assessment is to empower people to make their own choices, even unwise ones, then setting different thresholds for consent and refusal feels very paternalistic.
So it boils down to a fundamental tension between autonomy and beneficence, doesn't it? How much freedom do we allow people even when their choices seem risky? And when do we step in to protect them from potential harm?
Exactly. And there's no easy answer there. It's a constant balancing act, and it's a debate that continues to this day. Okay, so we've covered the foundational assumptions, those underlying principles that shape our approach to decisional capacity. But now, let's get meta. Let's zoom out and ask, are we even measuring the right thing?
Right. We've got these tools, these assessments. But are they actually capturing what matters? Are they valid?
Yeah.
And even more fundamentally, are the theoretical standards themselves adequate?
Excellent questions. So, on the practical level, we have instruments like the MCAT-T, which is based on that four abilities model we talked about earlier. And there's general agreement that it's pretty good at measuring those specific abilities as they've been defined.
Okay, so empirically it seems to hold up.
But there are still questions about how well it generalizes across different legal and cultural contexts. Like, how well does it map onto the specific criteria outlined in the UK's Mental Capacity Act?
Right, because different jurisdictions might have slightly different legal definitions or standards.
Exactly, but I think the more philosophically interesting question is whether the four abilities model itself is sufficient. Are we missing something crucial? Because critics often point to cases where someone seems to meet the criteria, they can express a choice, understand the information, appreciate its relevance, reason through the options, but there's this lingering sense that they're not truly capable of making a sound decision.
Like, the model says yes, but our gut says no.
Precisely. And that's fueled a lot of philosophical discussion about what might be missing. Emotions, values, authenticity, these are all candidates for broadening our understanding of capacity beyond just those cognitive factors.
So let's delve into those, starting with emotions. The Four Abilities model is pretty focused on the cognitive side of things. How might our emotional states impact our decision-making in ways that the model doesn't quite capture?
Critics argue that emotions are inextricably intertwined with decision-making, and that focusing solely on cognition misses a huge part of the picture. Our emotional outlook, our moods, our feelings, those can dramatically influence how we perceive risks and benefits, what we prioritize, what we're drawn to or repelled by, and that can lead to choices that, on the surface, might seem irrational.
Like someone who's severely depressed, for example, might be able to go through the logical steps of considering a treatment option, but their overall negativity and hopelessness might distort their assessment of whether it's even worth it.
Exactly. And there's research showing that depressed patients sometimes score well on those cognitive capacity assessments, but there's this nagging worry that their emotional state is skewing their judgment, making them less likely to choose what's truly in their best interests.
And this concern extends beyond just mood disorders. So
Mm-hmm.
addictions, OCD, anorexia nervosa, all of these involve powerful emotional states that can drive decision-making in ways that might not align with what we'd consider rational.
Absolutely. And it's interesting how, in our culture, we tend to value rationality so highly, sometimes dismissing emotions as these messy, unreliable things that get in the way of good decision-making.
But as a philosopher, I'd push back on that. Because without our emotions, without our effective responses, what would we even care about? What would motivate us to choose anything at all?
Exactly. Emotions are what give our choices meaning, what connect them to our values. The challenge, of course, is to figure out how to incorporate emotions into our understanding of capacity without throwing the baby out with the bathwater. We don't want to end up pathologizing every unconventional emotional response or create a system where people are deemed incapable just because their feelings don't align with some arbitrary standard of normal.
Right, that would be a slippery slope. Okay, let's move on to values and authenticity. These are two other areas where critics say the Four Abilities model falls short.
And these critiques often come up in cases where someone seems to meet the cognitive criteria, but their choices seem driven by values that are actively self-destructive. The classic example is anorexia nervosa.
Where the pursuit of thinness becomes so all-consuming that it overrides everything else, even basic survival instincts.
Exactly. There's a fascinating study by Tan and colleagues where they looked at individuals with anorexia who scored pretty high on that MCAT-T, meaning they demonstrated good cognitive capacity.
Wait.
But they also expressed a clear intention to continue restricting their food intake, even though they understood the risks, even though they knew they could die. Their value system was so skewed, so fixated on thinness that it seemed to override every other consideration.
Which raises the question, are they truly capable if their decisions are driven by what we might call pathological values?
Yeah.
Values that are themselves a product of the mental disorder.
Right, and some theorists argue that, yes, in cases like this, where the values themselves seem distorted or driven by the illness, we might have grounds to question capacity, even if the cognitive abilities are intact.
So it's not just about